Hi, welcome to this week's Telehealth Secrets webinar. I'm sorry we're 2 minutes late. Just a few quick housekeeping items before we get started. We do have slides and a handout for you in the handout section, so those can be downloaded. We'll also send the slides afterwards. You can type in questions that you have for Dr. Sadeghian or for Milton anytime that you want from the chat. And this session will be recorded and sent out following this webinar. And also we have more resources for you on reimbursement, telehealth grant funding, and just getting started. And you can check those out at vc.com/webinars, and also put that in the chat. So let me go ahead and pass the time over to Dr. Milton Chen.
Thank you so much, Anne. By the way, welcome everyone back. I hope you guys all had a happy New Year's. We're at the VC Telehealth. We're definitely pretty excited. We're just seeing a lot of activity, interesting thing, both on the technology and plus the big market forces. You see things like, Roman, Hims, all these huge company, making big movement on the stock market, impact, and so on. Then today, I'm really excited to welcome our guest this week, Dr. Reza Sadeghian, the Chief Medical Information Officer at Arrowhead Medical Center in San Bernardino, California. So the doctor is a practicing pediatrician and a physician technologist who's really passionate about using technology and reimagining how healthcare could be done. Again, all of you can see his long list of credentials, which is really, really impressive. But some interesting thing that you might not know about him, he's an avid photographer, loves to travel to remote places like seeing a sunset, maybe as early as 4 a.m., maybe a sunset that's late as 10:30 p.m. Again, when I saw one of his shots, it was just like really amazing, amazing stuff. I guess, how about maybe before we start, Doctor, maybe can you just share with us how did you, get started as photographer? Maybe right out of COVID, we all get the vaccine. Where would be the first place you're gonna go to?
Sure. Thanks, Dr. Chen. So, first of all, hello to everyone who is on the YouTube podcast. Yeah, so, as part of our journey to be a physician, we tend to travel a lot, right? You're going from hospital to hospitals, and, there are different rotations that we have to do. But even prior to that, one of the best ways to see, how beautiful our country is to have a road trip. And, America is great. We have a lot of beautiful sceneries in the country. And, when you fly, you don't get to enjoy as much as when you drive. So over the past 20 years, I was lucky enough to be able to move around, whether it was education or work or traveling. And we didn't have such a good cameras on our phones, and usually when we used to take a picture, we want to print it and put it on the wall. There was no social media, right? So you got to get at least a good quality of point and shoot. And everywhere that I was going, I really like to capture those as a memory. So that's how I started with the photography, and now in the digital world, you can take as many pictures as you want. It's not a film era that you basically burn the film. So that's how I got into taking pictures. And the more you go around and the more you learn about the photography techniques, it really became my main hobbies after hour of my practice.
Awesome. So can I ask, what do you use phone camera now? Or do you use actual professional camera now?
Yeah, so I have the professional camera with me every day, because you never know, you're driving on the highway in California and you see a beautiful sunset. So I pull over, try to find a place, but I use my phone to, capture just the day-to-day. We even have our own photography, videography room in my department, which I take pictures of my staff. So I carry my professional camera with me every day. I have 5 cameras, And
Wow.
so I usually carry the smallest one. But now with the software transfer, you can take a picture on your professional camera, so you have the file if you want to print out on a larger size, but then you can transfer also to your phone. So I use a combination of both.
Okay, awesome there. Thanks for sharing these. How about this? Maybe I'll turn the floor to you to share your insights, and then later on we open up to the audience for questions.
Absolutely.
Yeah.
All right. So as Dr. Chen mentioned, my name is Dr. Sadeghian. I'm a Chief Medical Information Officer. I'm also Assistant Professor here at the Arrowhead Regional Medical Center and also Medical Director of Clinical Informatics Department. So today I want to run you through what we did at Arrowhead using the VC technology and basically give you a little bit of background. Over 10 years ago, I worked at the University of Pittsburgh Medical Center, and that's where I did my first fellowship in biomedical informatics. But at the time, there was a lot of discussion about telemedicine, especially in a skilled nursing facility. So we rolled out a pilot study in our 5 skilled nursing facility. We built the technology from scratch. It was quite expensive at the time to even purchase one telemedicine card. So University of Pittsburgh had enormous resources in terms of software developer and technology, and we were able to do that. And one of the things that we did as part of our pilot and really learn is how do we go about building the platform, building the technology. Most of the institution, you would see that their IT department takes control of the technology purchase and have the stakeholders utilize it. What we learned was that how do we go about a complete project planning and processes. So one of the things that I did at Arrowhead prior to embarking on our journey with telemedicine was we created a telemedicine committee where we had a number of executives and physician champion on board, and really start looking into what do we need to do here. So we start working on our initial planning. We start looking at what are some of the areas that require to use the technology. We did an extensive evaluation of clinical practices. We look into our revenue cycles, right? Are these services that we're going to provide support for are reimbursed through an insurance or Medicare program? So we look into all of those before we even look into technology. As we were evaluating those at the time, obviously, we were interested to see from the clinical operation, what do we need to accomplish, right? When you have a patient that are coming to the hospital, we're looking at registration, we're just looking at the scheduling, we're rooming the patient, right? What kind of providers are going to provide services? So we're looking at an entire spectrum of a normal clinical practices. And what are some of the areas that we can replicate through technology? Then we're looking at the clinical workflow assessment. What is my care in a state? If I'm going to look into my family medicine, my primary care, my internal medicine, and pediatrics, what is the care in a state? And how is the technology going to help me? Or is there any room for improvement as part of my future state that I can leverage the technology? The third part was, is our IT ready for this? Do we have an infrastructure? If you're going to use this through, for instance, as simple as, are we going to use the Wi-Fi? Or are we going to have to use some of our desktop to provide this service? Are we going to use our portable carts on the floor? Do we have infrastructure and bandwidth that can do it? As I mentioned, we look into our revenue cycle assessment. Are these services under the state handbook for the telecommunication services are reimbursable? What do we need to do from the HIM and documentation perspective? Because now this is not a full-blown visit. This is going to be done through the telemedicine. So as you can see, as part of our initial design process, we had to get a number of individual engaged in the process. And once we evaluated the majority of this section, we went about who is going to be the best vendor for us, and we chose BC for that, for the reason that it really fit our clinical practice here. So I want to share with you our overall implementation workflow. So we were looking at how are we going to use the telemedicine technology? Are we going to use in our call center? Are they going to be the one who is the scheduler of this patient? Again, going back to that full workflow analysis. Are we going to use it in our outpatient clinic or inpatient? So when we look at the technology and we settle with BC, we look into what are some of the priorities for our institution. And coincidentally, it was the same time that we hit with COVID. So as we put our telemedicine community together, which was about November of 2019, and we were going through the process, all of a sudden we hit with COVID in early 2020. So we had to really expedite our evaluation and put a telemedicine work in place. And we divided into various phases. We start with our clinical. So we look into our clinical practice. How is our current state? We have a physician, we have nurse practitioner, we're academic medical center, so we have a large number of residents and fellow. So those are our frontline providers. How is the current workflow? The patient comes to the clinic, the CA or medical assistant room the patient after they've been registered in the front desk. So how can we replicate that without disturbing the workflow? Because some of our challenges are we're introducing technology. I want to be as close as to the current clinical practice, but also we're facing COVID. So we need to make some adjustment because of the situation that we're at with COVID. So we divided into various phases. We started with our outpatient clinic. We had about 33 virtual rooms that we created across the specialties. Then on the next phase, we want to roll out to some of our inpatients, so we engage our psychiatry, some of our consults. Then we also hit with the visitor limitations because of COVID patient. So we provided these resources for our nurses if they're going to want to have their family seen through the BC platform to use that. Then we also faced with our detention center. We have number of inmates that they come to the hospital. You know, we are a county hospital, and so the transportation was an issue. We also want to reduce the risk of virus transmission. So how are we going to go about that? So that was another phase that we worked to implement the technology in our county. So some of the follow-up patients, cardiology, follow-up surgery, were done through the BC platform. As we start to grow and more, then we were contacted by various departments in our county. The current work that we're doing right now is to expand the platform into our 54 skilled nursing facility, and that is through our Department of Adult and Aging Services. So we're not done yet, but as you can see on the screen, to just share with you some of the statistic, and to me it's quite remarkable. You know, we launched the technology in late July, beginning of August, and getting 33 virtual clinic on board in a very short time when you're understaffed, when a lot of physician leads had to go to a number of COVID-related meetings, a lot of issues across the nation with shortage of PPE and being understaffed. I think our hospital did a tremendous job. Our providers and our administrators, they did a tremendous job to align with my department, clinical informatics, to really push for this technology. We had over 552 sessions in the remaining of the year, and over 4,800 minutes of service. In 2021, we added one additional clinics, in addition to, as I said, expanding to 54 skilled nursing facility that are rolling out actually this week. So we have we have had so far about 151 sessions, and the numbers are growing. So again, I got this number yesterday, and if I log into our VC platform, I'm sure those number has gone up since yesterday. So our physicians are very receptive to the technology, very receptive to the technology, and they're really wanting this to expand across our institution. We're also getting some feedback from other county department, in addition to the detention center, that they really want us to help with that platform. As a pediatrician, I still practice. I think that is very important to be a physician informatician and practice, and basically bring something to the table that I myself would be the first one who use that. It's like our COVID-19 vaccine, right? So who's going to be the volunteer to use it? And so I just want to share with you a story that it happened among many stories a couple of weeks ago. And I had a patient that the mother had COVID, and unfortunately she wasn't really doing well. So when the baby's born, they had to have the family to take care of the child. So they wanted me to talk to mom via phone. So it's part of our phone visit. So when I called them and I talked to the mother, and I said that, you know, we have a video visit, and if you would like us to send you the link, you're able to come online and I can see you and the child. And say, well, the child is not with me. The child is with the family member. I said, that's fine. You know, you can log in and we can start a discussion. And then once we start the session, I will ask you to send an invite to your family member and send them the link. And through that link, they're able to join. So one of the great things about VC is that once you start a session with a patient, there's going to be associated link and a pin with the phone number that you can share with additional people, to my knowledge up to 10. And so what we did, mother shared that link with the family, and they were able to join the call. And we had someone similar to the picture I posted on the screen, a three-way call. So not only mom was able to talk to me, I was able to talk to the family member, see the child, and also mom was able to see the child. So I think this is just one of the many examples out of those 500 plus sessions that we have, that how such technology can help us even during this time. Another example that I can share with you is that the emergency medicine. Usually with the emergency medicine workflow, physicians come to work and finish their work, and they go home. So there's not much continuity of care. With COVID, sometimes when people come and we test them for COVID, and for whatever reason we send them home, that they don't need to have an inpatient hospitalization, they want to follow up on the result. Obviously, we have a patient portal, but due to some of the challenges with our patient population that we have in terms of technology and being able to get access to our portal, so we follow up with them through the phone call. And one of the things that our emergency department really want to do is that, especially during this time of pandemic, it's better to have a face-to-face visit with family rather than just a phone call that, hey, your test is positive or negative. So for a lot of our follow-up calls, we actually use the VC platform, and we have received a tremendous positive feedback from our patient that is a lot more reassuring, even when we're having to call them just to give them a test result, especially for COVID. We can sit with them face to face at residence, grab a room, send them a link, they come online and talk to them. And if they have any further question, their test is positive, and they have question, are you symptomatic? Are you not? What are the next steps? So we realized that the value is significant when we set up a video session instead of just having a phone call to even discuss about the simple lab result. So this is just a quick overview of what we have done with telemedicine here at Arrowhead. So I'm going to pause here and open this to discussion with Dr. Chen and the audience.
Great, Doctor. Thank you so much for sharing insight. Really impressive what you have done. And I think as we're gearing up for open up question, we're going to do a quick poll for the audience members. And the reason we have this poll is really just to give you a sense, audience, just what level of, telehealth expertise you have, and have you guys started to try something, how many different systems you have tried, and so on. And we'll give you a couple of seconds to do this. And great, and Anna will share the results as soon as we process this. And I think, Doctor, it was really exciting to see you guys did a lot of planning before you actually dive into telehealth. I know a lot of the, oh, great, okay. Okay, so this is actually great to see. It seems like quite a bit of you have quite a bit of experience in telehealth in this. Yeah, this is, by the way, we will also see this in the general markets when we survey with a client we work with. People tend to start out with something like Zoom or Microsoft Teams, and then able to jump back into, like the exploring the different way to go just beyond video to actually have these more like telehealth workflows. Thank you. So again, Doctor, I was interested. So a lot of the people in our audience member, they're really interested in the practical side of implementation in there. So what, how much planning did you do before you actually dive into this? I was just curious, is this something that took, is it hours or days, or just how much time do you, until you felt like you had all the pieces in place?
Yeah, so as I mentioned in my very first slide, I spent a few weeks talking to our department leads, and I tried to focus on the primary care first. And I also, as I talked to their department chair, I asked them what they think about some of the usability of technology. For instance, if I'm talking to general surgery, I asked them if they think that there's any utility of this in some of their subspecialty group. And I took their initial feedback, and if I needed to go and talk to the subspecialists in more detail, I talked to them as well. So I would say, since November of 2019, I spent about 2 months trying to really get a good grasp on the clinical workflow assessment and their needs before I even look into the possible vendors.
Got it. That makes sense. So we have a question from the audience, Dawn. So she's asking, so are you seeing any issues with the elderly and their understanding of how to join a virtual session?
Yeah, so one of the reasons that I had in mind for the technology is that I want to make it as simple as possible for our patient population, because there's an elderly population that we have, but also we have people that are not really tech savvy in our patient population. So these were always in my mind, and we try to eliminate some of the obstacle. For instance, if you can eliminate the need to use any applications, that is a plus. Which means that if you have an in-browser login, that is going to help tremendously. So that was one of the reasons, again, with the VC, you have an option of both. And since our workflow was very simple, you just click on the link and get a session. Now, if I'm following with a patient with a congestive heart failure, and as part of the training, some of the things that I told the care assistant and MA was, if you can get a family member with them for the first time, that is going to help them out. Otherwise, as part of our training, we taught them how the patient interface look like, so then they can troubleshoot for them. So if you are calling the 70-year-old and they want to be on a video call with their doctor, you need to troubleshoot at least the first time. When they go through the link, okay, click over here. Okay, what do you see on your screen? First name, last name, date of birth, right? And they try to stay on the call and troubleshoot with them, and they get them on the platform, and then they hung up on the phone. And then the second time, it became easier for them.
Okay, that makes sense. So I have a question from the audience. Raluc asking, so how were you using this for telemedicine, in terms of during the COVID within your hospital? And also then the second part of the question is like after COVID is gone, how do you see it used like outside of the pandemic?
So for our inpatient setting, we use it mostly for our consult. So for instance, if they want to get a site consult and we want to reduce the face-to-face interaction, like in person, we use that for those reasons. Also for some of the subspecialists that they did not need to be at bedside. For instance, if the internal medicine is getting consult from infectious disease, they're talking about the case, they're reviewing the labs, or some other consults, we use that for those purposes. Most of our usage was in our outpatient clinics.
Okay, got it. So
now, post-COVID, I feel like the technology, now that we had a reason to push this, and bring it out faster because of COVID, I think physicians and our clinical operation, they started realizing the value. I think there's still a room for the technology post-COVID that we can leverage. As a pediatrician, there are so many cases that I can see without parents bringing the child to the clinic. For instance, if a child has a rash and some other symptoms that they don't need to bring them to the clinic, why would I want them to bring the child and expose them to other sick children sitting in the waiting room? So now, especially with the advancement of your phone and your iPad cameras on them, right? Once we conduct a session, it's so much easier to visualize that. And if there's any doubt, we always ask them to bring it to the clinic or send them to the emergency room.
That makes sense. So one of the things is like I probably get like a daily some Wall Street analysts ask me like just asking. So everyone predicting regarding to stock prices or Teladoc, American or something. Right? So say like right now the COVID have a bump in there, right? If it's COVID, does that curve look like you flatten out like in terms of telehealth adoption? Does it trend downward and settle into some place, or does it continue going up? What's your prediction?
I think it's all about recepting the technology, and I think what we're going to see is different institutions are going to use this differently. I mean, 10 years ago when I was at University of Pittsburgh, we were the pioneers in those type of technology. One of the reasons was UPMC has its own health plan, so we were not worried really about the other insurance that are going to pay for the service. But also, we were really good with technology and physician leads that they were part of this. So I think one of the things that's going to happen is we're going to see some institutions are going to leverage this more than the others, because during the pandemic, they really tested the technology and they really compare in different clinical settings, and they saw the value of this. Now, the problem is going to happen if we're going to lose some of the payment plan that, some of the restriction that the Department of Health and Human Services did during the pandemic. If those restrictions is going to be put back in place, obviously we're going to have a little bit of problems.
That makes a lot of sense. In the end, it's just the payment will move the needle.
Yes.
We have an interesting question from Zach. So he's asking, essentially the context is, right, so if you have this virtual waiting room, all these pieces, right, while the patient's waiting, so today they're not doing anything. So he's asking is from the media and marketing perspective, what do you think about placing this ad, like the video ad in front of the patient and the healthcare provider, as they have these telehealth experience. Like, what's your feeling about that?
So between the time that the patient is in the waiting room and it's waiting for a physician to join the room to have an ad on the screen.
Yeah, my hunch is could be while during the. I think there's. If I were to guess, Zach, I apologize if I but if I were to interpret the question, I'll say one is while the patient and the healthcare provider before they have a session, they're on the platform, you could show some ad. So the other piece is while during the conversation, and maybe there's various relevant other material that could be served out, or maybe after they see a visit, some additional video content played on.
I mean, certainly it's an interesting idea. The only thing is that, as I mentioned in one of my slides, our average visit was about 7 minutes.
Okay.
So I think it's interesting, and I think if you can think of some educational tools that is relevant to those practices, but also from a technological standpoint, my question is always like, many years ago, the video session would take a huge bandwidth, and now with all this advances in technology, we have reduced that. So the only thing is that if you're adding additional workload into the session, is it going to really put more on? Is it going to use more bandwidth on the session and create interruption? That's one thing I would ask. And the second thing is that what are some of the content that we were looking? Because for me, the 7-minute visit is pretty fast.
Okay.
So if I'm putting additional contents in between, because we want to replicate the regular workflow in the clinic. So as soon as the CA finished, the doctor will go in, maybe 30 seconds there in between or a minute. But I think certainly it's a good idea to explore options.
Okay, got it. Okay. The reason that my hunch what Zach is asking is sometimes these content are sponsored by the pharmaceutical companies. So some people feel like making sure it's not like overtly advertising or maybe find the right gray area.
Are we going to charge those content to offset some of the cost of VC?
I think there could be. We can talk on. Yeah, in fact, we do have an engine that actually you could do content through different pharmaceutical companies, but you could also serve out, for example, from your hospital, you could put out relevant content before the visit happens.
I think certainly is an interesting idea. I think even if from the hospital perspective, I mean, again, you got to look at your statistics. What is my average time and what is my wait time? Because you can also do a wait time report. If the wait time is long and there's no way we can change the operation, you can certainly talk about your hospital, right? Yes.
Makes sense. So we have a question from Alan asking, so on a practical level, so do you how many hours do you have to deal with these, like these or more like the technical support type of things, making sure someone has a microphone or camera, and do you have an in-house technical support team that sort of support your, the type of operation?
So the way I usually go by the project is to follow the project management process. Again, the first slide. So I have a team in place and I work with IT. My department, clinical informatics, works with our IT department. So before we went live, we identified all the areas that needs to have a camera and microphone. We also engage our compliance to ensure patient privacy. And we went about and tested all the stations to ensure that they're working. We created a cheat sheet instruction to put it on every station, because when people come for an hour of training on how to use VC, and this is certainly not day-to-day practice, by the time they come back to use it, they might have forgotten how to log in, where to click. So we really summarized the entire process in 2 pages and put it on every station for them, put in laminated paper. We had 3 ways of support. The first line is that every department that we implemented the technology, I asked them to give me a champion. So physician champion for every department is the first person to go to. And the second line is the phone number we provided. So we have a service from 8 to 5. And since it's mostly outpatient, so we don't need after-hour support. And they would call that number. I was also available since a lot of physicians, don't call IT or call the support, and they always call me or text me directly. I had the master login access to our VC platform, so if they forgot to set up their password or they want to reset immediately, they just text me and I just pull up my laptop and I fix it for them. And we didn't really have any technical problem besides some area in the hospital where they tried to use Wi-Fi. Some of the sessions were kind of broken, but that is the problem with our Wi-Fi connectivity and not really technology. So with especially having the champion in every division, we found out that it is extremely helpful.
Okay, thanks. So Yahya is asking for the question. So he's asking, so have you developed any remote patient monitoring solutions where you things like really pull on data beyond just video from a patient?
So we were thinking about that, especially with our inmate population. So we just purchased full telemedicine technology from VC, and we're looking into integrating some of the devices through iHealth that they provide for our patient tracking. It's a little bit more complex, because then you have to look into how you want to integrate it with your current EMR versus you want to upload those information on the VC platform. So, but this is certainly what we're looking at right now with our inmate population.
Got it. Great. Okay. So I have a question from David asking, so when you onboard a new physician or a nurse, like just how much time do you allocate for training for from this new provider to feel comfortable, become really good at telehealth?
So we only spend about 30 minutes, believe it or not. Again, efficiency and simplicity. We try to focus on the area they need to work on, and 30 minutes of discussion over different platform that we have on the front face, patient facing, and the physician facing, and literally a demo. And again, our institution, we have a number of residents and fellows. They're running 90% of our clinical practice, and these generations, they know the technology really well. Sometimes I send them my slide deck and they come to the session for our training. They already know everything. They already tested the system in our test environment. I just need to set up their username and they're good to go.
Got it. So this is actually great to hear that you're constrained. Now, within your provider, do you find that is there a pattern for people that are provided that get like a 5-star rating from the patient versus maybe like 4 or 3 stars? And is there do you find like for the people who get maybe 3 or 4 stars, is there additional training or what type of training that could get everyone to like a 5-star?
Well, I think one of the challenges with providers is, especially when the COVID, the number of cases increased, when some of the providers that they were more senior and they wanted to see the technology, see patient from home, then they had to use the technology themselves. When they were on campus, the residents were the one who initiated the session and they were using it, but now they're at home, they don't have that resources. So I think that was the challenging part for some of our providers, that all of a sudden they had to use the technology that they basically sat in the class for training, they use it once or twice, the rest were done by residents and fellows, and then all of a sudden they faced the situation that, oh, now I have to see the patient myself. Where is that cheat sheet? What is the number we need to call them? And I think that was a challenge some of the more senior attendings faced.
Got it. Okay. So I have a question from Amit. So he said he's a CTO of a big healthcare system. So they say they're doing before they're doing about like 2,000 sessions per week by telehealth. Then now with the COVID, they're doing about sort of like I guess it was the beginning they do about 20% of these for 2,000 sessions per week with telehealth. So now about 95% are telehealth. So he's asking is, so between the different departments you have, is there a certain department that have a lot more adoption than other? And then the second part is, what is a best case scenario, like what do you expect in a pediatric a certain percentage telehealth access, and then some other department maybe higher or lower? Because what is the norm for like adoption?
So talking historically, I always anticipate that someone like psychiatry would be the best, would be the highest, because even over a decade ago when I was building the technology, we didn't need any diagnostic medical equipment, right? You just need a face-to-face visit, HIPAA secure face-to-face visit. So I think it depends on the providers and the champion in each institution, because I was hoping that in my institution also I see that number to be the highest, but I saw that my internal medicine was actually the highest, followed by family medicine. And now I'm looking at every week I'm looking at the trend, and when I have meeting with our medical executive committee and department chairs, I bring the statistic to the meeting, and it's interesting. Now my maternal fetal medicine is like going up. So I think it all goes back to how much the providers are buying into technology and how much they're willing to use it. If all my providers and physician champions were tech savvy, I would say that I would see number one would be psychiatry, number two would be the primary care, and number three would be more of a subspecialties. So I don't see much in my general surgery, but I see a lot in my neurosurgery, which again, to me, it's very interesting. My neurosurgery is having a lot more follow-up session with their patient through VC than my general surgery, which I thought the number would have been reversed. So when I present this in medical executive committee, sometimes it's interesting to see that we see like internal medicine is like number one right now.
Got it. Okay. Thanks for sharing the insight. So we have a question from Mohammed asking, so have you got any complaints from patients that like the provider made some mistake over telemedicine? Again, the premise for this, right? In person, you have all these in-person exam and so on. But when you're doing telemedicine, often you're very limited to just the medical history plus the video.
No, I think the problem that we had with some of our patients is how to really use the technology. Okay. Because when we see a patient remotely and they're not used to it, especially older population, and I try to when I do my training with the care assistant and medical assistant, I try to have them use some of the examples that they may use in normal life. For instance, if you're teaching your patient that are 65, 70 years old, try to use some of the examples that they use in their regular life, in their normal life. For instance, do you have any grandchildren? Yes. Do you guys use any FaceTime? Anything that you see your grandchildren? And try to leverage some of their normal life pattern to replace it with the technology. That is a complaint that usually they have is, how do I use this? And when you simplify that for them, it works so much better. Now, some of the patients, they do not like this type of technology. They like to come and see their doctors face to face. Even if the camera is face to face, they still like to have that, welcoming and shaking hands and, old fashioned. So unfortunately, we can't change that. But teaching them and helping them and simplifying this, and again, it goes back to one of the features that we're not using app is a huge plus, that they don't need to download anything, because that would make things even more complicated. And I think helping them to walk through the technology and ease this step is the part that some of our patients are asking us to do for them.
Got it. So then, do you develop a medical guideline for your providers in terms of, here's a set of conditions, you need to do it in person, here's the set you could do video? Is that done by individual departments or physicians?
So as part of our analysis, again, as part of the workflow analysis in the beginning, we sat down with them and I asked them, what are some of the scenarios that you think we need to have these people on the telemedicine. It's feasible. And this part is actually very challenging because you have to bypass some of the other steps. Normally, when the new patient comes to the hospitals, they call the call center. The call center assigns them to different specialties. Once they come to their specialty, let's say the patient comes and see a family medicine doctor, the family medicine doctor will schedule the next visit through their own clinic. So it will be extremely challenging to train the call center which patient goes through in person, which patient goes through the phone visit, which patient goes through the telemedicine. So what we did in the initial phase, we removed the call center from our to make an appointment for telemedicine at all costs. So they just schedule a patient for our clinic visit. The medical directors put the setup information for the nurse triage so that when the patients are calling and we're scheduling them, they can talk with them and inquire about their upcoming visit. And basically, they kind of filter them as this person is coming to visit, or we also have a video platform. And last things, but not the least thing, we try to switch all of our telephone visit to video platform.
Yeah, yeah, that makes sense in there. So right now, like one of the trend, like in the general, I guess especially on the for-profit side of telemedicine, are company like Roman, Hims, GoodRx, Hey Doctor, and so on. In fact, Hims, I think they just became a public traded company last week, like billions of dollars and so on. And their model is they're not even doing video visit. They just have the patient fill out some questionnaire. And from the questionnaire, then some doctor review it, they write a prescription. Like for that one, do you see that is something that you want to augment your existing thing? Or do you feel that type of practice is maybe like medically, you just don't have enough information, is maybe too risky? Or
I mean, I personally like technology. I mean, I'm a CMIO here. That is not something that everybody likes, the providers. I mean, the challenge is that technology is changing much faster than healthcare is adapting to. And I think the biggest challenge that physician informaticians or folks in the C-suite, chief technology officer, chief strategic officers, chief information officers are facing is that how do we go about educating the needs not only to our system but also to our providers? Because at the end of the day, those providers, the clinic operations, are the one who's going to use this technology. So I'm always open to look into the trends and see what is out there that can provide better patient care for my community, and what are some of the options that I can embed into my system that my providers would utilize. So there's always that balance that I have to keep in mind going about any changes that I see on the news or the technology trend in different part of the country.
Got it. Great. So I have a question from the Give More. So she's asking, like she's just using Zoom for video call with her patients in there. Like, of course, that's really easy. She doesn't need to do anything. Just send all these links in there. Like, what do you gain from going through, set up the whole telehealth program versus just like everybody just download Zoom and do Zoom calls?
So as I said, it really depends on your clinical practice. It really depends on what your workflow is. If maybe you're a social worker and you just want to set up a call and talk to someone directly, it might work for them, that they have that kind of platform. The way I see the technology that worked for us, I really want to replicate the clinical practice so that I eliminate unnecessary step to train, and I can have my team to continue to use the technology. This is like the rule number one that I have in my book, that every time you introduce a technology, try to stick to your current workflow as much as you can, unless you're changing your workflow for better needs. Introducing two separate workflow is not going to be receptive. So the way I want to create my workflow was, if the patient is when the patient comes to the clinic, they go to the front desk to register, right? Then they sit down, they get called in by the MA or CA to go into the room, check their vitals, fill out the questionnaires, put some information in the medical record, and then they said, doctor will be with you shortly. Then the doctor will go to the room, visit the patient. If they need to have any follow-up, for instance, to get the nurse in the room, like in my case, the child needs additional support or not, or I'm done with the session. That's one workflow. In the academic medical center, sometimes you get the intern or residents to see the patient. You want to do round on the patient, family center round, or you want to bring the subspecialist or the attending into the conversation. All of those combined, I want to create a system that is very close to that. Yeah. So Zoom wouldn't do that for me. WebEx wouldn't do that for me. And we have institutional account with them that we use for other purposes. But looking at the vendors, BC did that for us. So when I have the session that the care assist go and see the patient and ask those questions and said, the doctor will be with you shortly, the care assist can leave the session, but still keep the patient on the cloud, on the waiting room, and then the doctor will log in, go see the patient. Also, if this is done through my residents, they can send a link to the providers, to the attending, so the attending can join the room, and then when they talk to the patient, they can leave the room. Same thing with subspecialists. They can do that as well. Some may argue that, we might be able to, we can do that with the Zoom as well. But for me, the workflow is so much easier because we tried Zoom prior to going with BC. And it was very cumbersome because you have to also, almost like scheduling a meeting. But this is like on the fly. You just send them to the text message and the session is there. Also with Zoom, the other challenge is that with this platform is that you need, you have a limitation is in terms of number of sessions that you can schedule per hour, versus if I'm giving an account to my surgery clinic and my MA is covering general surgery, urology, ENT, and ophthalmology at the same time, those doctors can see the different patient at the same time, so they don't have that limitation either.
Yeah. Got it. That makes sense. So Sam is asking us, what for your patients, what percentage of them uses like mobile versus desktop?
I would say that almost 100% of our patients use the text messaging feature, which goes to their cell phone.
Got it. Okay, so very mobile. How about on the providers? For your provider, do you train them all? Do you tell them they have to sit in a nice office to a lot, or do the provider will also do telemedicine call on their mobile?
Those nice and fancy offices only in Grey's Anatomy, right? My providers are always on the run. It's either their cell phone or we have a charting room that they're sharing with a number of people at the same time. And so we have a dedicated computers in every charting room with a camera and a headphone for privacy. But also some of the providers that are program directors, sometimes they go back to their office to see the patients. We provide service for them. But I also have providers that they said they use their cell phone in the hospital.
Yeah, got it. That makes sense. We have a question from Scott. He's asking, so now you have done so much already. If you could go back and do it over again, like what would you do differently based on your now what you learned?
I don't think we would do much differently. I think as an organization as a whole, I think if I raise that question at a higher level, I think my our operation team and some of our executive probably would have done some steps differently, and those would be, we need to have, in your institution, you need to ensure that there's a great collaboration between different pieces. So just because my department did a thorough evaluation in the beginning, we got the vendor in place, we got our IT on board, and we got our physician trained, that is still not enough. You need to ensure that every member of the system work collaboratively together. for instance, who is in charge of your registration? Who is in charge of your scheduling? That may be under totally different administrators that you need to ensure they're aligned with each other. And I wouldn't really blame my administration on that too, if I were to do it again. I think the challenge with COVID was it was fast, and we lost a lot of staff. And that was the challenge for the registration team, because if my MA or CA is going to look into, is working on getting the patient into the room as part of the in-person visit, but also we're asking them to set up a patient through VC. I mean, if you don't have enough staff, that's not just feasible. So if I were to go back, that's a really good question for our legislature as a whole, that, you know, the telemedicine was very stagnant for years in the United States when you compare to Canada and Europe and the rest of the world. And if COVID wasn't there, I don't think we would be here today. So I think the lesson learned is that the technology should be welcomed faster than what we have done in the past, and how we can work together, you know, as a nation to really incorporate that into our healthcare system.
Great. And Doctor, thank you so much for your time. But I apologize, there's a still bunch of questions and audience that we didn't get to, but we'll give this answer or post on the webpage. As we're closing, maybe I could just ask you three really quick rapid fire questions. So the first thing is, you know, as a physician and, you know, IT experts in this, what was something that you find that's really surprising about sort of telehealth?
So I think the surprising part was how readily system have embraced our healthcare system have embraced telehealth in all areas of medicine. This would not have happened without pandemic forcing this issue.
Got it. So the next thing is, so now you're one of the experts in the industry in there. What is something that, like, there's one thing that you believe about telehealth, but the rest of the world do not believe yet?
Well, I'm not sure about no one else, because I think those of us in telehealth all realize its potential. I think there are a lot of people that have been in this in healthcare industry and technology, that they're very aware of these challenges. But there are still executives and physicians that they do not understand how useful the telehealth can be in the practice of medicine, and how quality medicine can be delivered this way. So I think a lot of us, it's just not, you know, specifically limits to me, that people think that we need to have more providers and executive on board as part of this effort.
Great. And the final question is, if you have a magic wand, you can make one big change to American healthcare system. Maybe even, for example, I know President Biden, he's very active in digital health. He's always come to speak at like Startup Health. I remember sitting in the front row with him, right? Like, what will you whisper into his ear? Like, then he'll do something big in healthcare. What would be that one thing?
Only if I had a magic wand, right? So I think technology is changing much faster than what the healthcare is adapting to. I think there needs to be education on the use of informatics in the delivery of healthcare, on the use of electronic medical records. I think there needs to be more integration of the providers in choosing the technology that a hospital uses, as they are ultimately the ones using it to provide care. There needs to be much higher value placed on using clinical informaticians in healthcare system. I mean, in my hospital, I have clinical informatic rotations, and we have a School of Medicine here, CUSM, California University of Science and Medicine, and we have St. George's University students over here, and all of our residency and fellows. So we have students rotate through my clinical informatic rotation. We have now a fellowship in clinical informatic rotation across the country. And so I think that the sooner we integrate some of this knowledge into their medical curriculum, and also bringing our next generations of medical students and residents up to speed with the changes in technology and introduce them to those, I think this is going to help our healthcare system tremendously over the next decade.
Awesome. Again, thank you, Doctor, for your really insightful presentation and wisdom in this. And thank you, everyone, for joining us this week. So we'll be sending out the recording and the slides following this session. And also, please take our survey as you lead the webinar. We always love to hear from you so we can improve how in this. And then we're again looking forward to joining us on the next Telehealth Secrets webinar. Again, thank you again, Doctor.
Thank you very much for having me. All right, safe. Have a wonderful day.
Thanks.